Well, good morning. It's good to be with you and glad to be able to talk to you today about normal tension glaucoma. I have no financial disclosures. The study was initiated because of a 1984 meeting sponsored by the Glaucoma Research Foundation in San Francisco to discuss normal tension glaucoma, which was puzzling to clinicians at the time. Many thought that normal tension glaucoma was not really glaucoma at all, but it was a pseudo glaucoma. It just looked like glaucoma because normal pressure should not be harmful and probably isn't, according to their reasoning. Therefore, lowering of intraocular pressure would be of no benefit in these cases. And what you should do is simply look for the actual cause of the visual field loss or whatever was discovered. Clinical intuition was mixed, however. Some people, unable to find a different cause for the cupping and field loss, tried treatment, and they didn't find that it worked. It was difficult to lower the pressure from a normal level, for example. And they questioned, does that mean that the intraocular pressure is not involved? Or maybe the pressure wasn't lowered enough by the medications and laser? Surgery, if they chose to undertake that, had some risk of hypotony, for example, and in face of an uncertain benefit, clinicians were hesitant to undertake surgery. However, there were some clinicians who did undertake surgery, aiming to get the pressure down into the low normal range instead of the mid or high normal range, and they said that it did work in stopping the progression of the visual loss. So in a follow-up meeting, it was decided that a study should be done in order to determine whether the intraocular pressure is or is not involved in normal tension glaucoma. And that was assigned to Stephen Drance and me to design, which we did over a period of several months and discussed back and forth various ways to design it. It was not designed as a intent to treat design. Intent to treat is a design where you say that you're going to start treatment, and no matter what the result was, you followed up and found out whether or not it gave benefit. Whereas we decided that we didn't want to do that. We wanted to compare cases where the treatment had been effective in lowering the intraocular pressure to those that never even made the attempt to lower the pressure. That design was then reviewed with all of the potential collaborators, and the people decided that they did want to become a member of the group or not, and 23 people did sign up, and the first patient was enrolled in 1988. There was a different opinion about what the outcome would be, of course. Some people were more inclined to think that that treatment would work. Others thought no, it wouldn't work, and everyone agreed, at least they didn't know for sure, they just had an inkling. Only one eye was enrolled, and that was done for ethical reasons, that you didn't assign both eyes of a patient to a treatment that wouldn't work or had side effects. So we had the results, but along the way, before we got to the final result, we learned a few lessons. The first lesson was that 30% lowering of pressure could be achieved without surgery. Now, the only medications that were allowed were pilocarpine and laser. Actually, that's not a medication, is it? But those were the only two treatments allowed. Any medication such as a beta blocker or epinephrine that could conceivably affect blood flow, and it was known, for instance, that there were systemic effects, and of course it affected the optic nerve blood flow from the new drug of the beta blockers that had just come along. But we didn't want to have the effect of the drops on the outcome be a result of vascular effects that were systemic, but we wanted them to only deal with intraocular pressure. So 30 patients were randomized to treatment. 8 were controlled with pilocarpine alone, and 9 more with laser trabeculoplasty in addition. So 17 patients didn't need surgery. And this was something of a surprise because we thought this was going to be, in the end, a surgical trial where we determine whether surgery was helpful for these cases or not. There were 13 that had fistulizing surgery, but 3 of these had the surgery without even trying the medications or laser. This was the first surprise, and here is the reference for it: intraocular pressure reduction in normal tension glaucoma. The second lesson that we learned before we got to the end result was that visual field testing was non-specific. We did visual fields every 3 months, and the criterion was that if they showed progression compared to a baseline of the average of 3 baseline visual fields, then a second field had to be done. And then if that was negative, they had to have a third field. And they had to have 2 out of the 3 positively different from the baseline in order to consider that they had progressed. And we thought for sure that would be something that would be without false positives. However, by 1990, there were too many endpoints in both arms, such that already more than half, maybe 2/3 of the patients had reached an endpoint of progression within the first year or 2. And it was because we were testing the field so often, and the chance of getting a false positive cumulatively increased so that it happened to most of the patients. We realized that we were never going to find the answer. And we found a method, actually devised a method where we could show how many of the endpoints were actually true endpoints and how many were likely due to chance, because we'd been doing the field so often and we just happened to get a field that was different from the baseline. Well, we found that 1 was genuine and 17 were false positive endpoints. But we didn't know which one of the 18 was the one that was genuine. We just could calculate that of the, from the probabilities, we could calculate that 1 was true and the others were false. So our second new insight was that visual field testing gives frequent false positive progression. And because of this, the endpoint criteria for the normal tension glaucoma study had to be modified. And it was modified such that there was a reconfirmation of progression in 3 months. So the same series that was done to get tentatively a sign of progression, 3 months later, you would confirm it before you would count it as a true endpoint. Now, we know from other clinical data, meanwhile, it has been shown that when you take fields over and over and over again, you'll get false positives, and that to get a true positive, you had to, if the person had to be truly progressing at a rate of 2 decibels per year in the MD, and there had to have been at least 2 years that elapsed to give enough time for progression to have truly occurred. Otherwise, you're going to think in terms of it being a false progression. And that's clinically useful to know, so that if you repeat fields and you're following a patient, you have to be sure that you've gone at least 2 years and have at least 6 fields before you come to the conclusion of progression. That's the clinical take-home for from these studies. Here is the references for this second new insight. Well, we learned then a third lesson, and that was the ultimate result of the study. With the Kaplan-Meier curve, a person showed progression. Here, somebody showed progression at a year, and there's another one before about 2 years, and so on, in the treated group. And after about 7 or 8 years, or maybe 5 or 6 at least, 20% of the people had shown progression, but there were 80% that remained that had not. However, in the control group, there was progression that was much faster, more frequent, and at the end of 5 years, all but 40% had progressed, statistically significant. However, people who looked at the data of the study had another question, and that is, what about the intent to treat analysis, which was usually required from randomized clinical trials, which is to say that if you treat someone and they didn't get much effect from the treatment, you can't just drop them from the analysis. Because what you want to know is whether you intended to treat them and you continued the treatment even though you couldn't tell its effectiveness at the moment, you would still keep data on them. We hadn't done that, so that was difficult to get that analysis. But when we did that kind of analysis, we had to thin the data so it was equal between the two groups that were being compared. We found that the number who were surviving without any field loss was not different statistically. And that was a disappointment. But we realized that some of these people had visual loss that was not really an endpoint in glaucoma, but was due to the fact that cataracts had developed meanwhile. And this happened more often in the treated group because it happened in the people who had surgery, which was, as you remember, about half of the people had surgery and they developed some cataract. And what we had to do was, at the time that cataract developed, when the visual acuity dropped by a certain amount and the clinician confirmed that there was cataract present, we stopped using data from that person. When we did that, then there was a difference between the treatment and controls, and it was statistically significant. Here are the results reported in the two papers, one not correcting for cataracts and the second one after correcting for cataracts. There was still more to be learned, however. We wanted to know what the natural history of glaucoma was without treatment. We had a number of untreated eyes by this time, 49 of people who had been randomized not to be treated, 56 who were still being followed without treatment, because before you could enter the study, you had to show that you were a progressive case and not a stable case. And 56 of the people had never been randomized because they never showed any progression in the first place. 31 were promptly randomized to control because there was a history already of progression when they entered the study. And there were 24 who had a long time of being not treated before they finally progressed and were randomized to no treatment. Here is the natural history, again with a Kaplan-Meier curve, each tick downward representing another case that showed progression. And you can see that over 5 years, or 6 years, or 7 years, why not quite half had shown progression. And so there are many cases of normal tension glaucoma that don't progress. Another way of studying progression is to follow the mean deviation slope. And the slopes are represented by the numbers over here. So from the starting point, there were this number of people in whom the slope was positive, actually. And then a lot more people where the slope was negative. But statistical significance occurred only in plus or minus 2, judging from 1 over standard error. Never mind the mathematics. These people here had a false positive slope. And these people here had a potentially false negative slope. The only ones that really count were the ones down here, whose slope was greater, for one thing, and also statistically significant. If it was underneath this dotted line, those cases were statistically significant. So in total, there were a bunch of people that didn't show any progression, although they may have shown technically a progression, it wasn't statistically significant. And there was another bunch that showed progression and it was statistically significant. And the amount of progression varied. Sometimes a half a decibel, sometimes 1 decibel, and sometimes 2 as an outlier over the course of follow-up, whatever they had. The amount of follow-up, the length of time, it's the distance from the origin to the arc or to the point. So this person was followed a short period of time, this person a longer period of time, as was this person. And this person here and that person there were followed for the longest of any of them. So the conclusions from the natural history study was that half of the patients with normal tension glaucoma show recognizable progression in 5 to 7 years. Most of these progress slowly, but importantly, there's a broad spectrum in the rates of deterioration. And remember that in 7 years, only half had progressed at all. What's the explanation for non-progression? Well, some of them may have been congenital anomalies that looked like a glaucomatous disc and had stationary visual field loss. Others may have had self-limited single event in the optic nerve. For example, at the time of a major hemorrhage or shock or something, came to the emergency room. The question I ask patients is, have you ever been so sick that they thought you were going to die, but you recovered anyway? And that's time when the nerve may have been damaged. Now it's not getting more and more damage because the event that occurred is over with and they've been cured of that. There have been cases that have certainly been documented like that. And some may simply be progressing too slowly to be recognized as progressive over a course of 7 years. And of course, there are ones that clinically you might have less concern about. Here's the reference for the natural history of normal tension glaucoma. Clinically, it would be helpful to predict what it is that determines whether progression is going to occur in a particular individual and whether it will be fast or slow. For that reason, we undertook an analysis to recognize risk factors. And that takes us to the 5th lesson that came from this study. Well, now for lesson number 5 from these data. What are the risk factors for progression if you didn't treat them? The risk factors that influence the rate of disease may not be the same as the risk factors for having the disease in the first place. Factors affecting the likelihood of having normal tension glaucoma come from prevalence data. Factors affecting the progression rate is discerned from progression data. And that's very different. For example, here we have progression with and without disc hemorrhages. People who have no hemorrhages progress less often and more slowly. And those that do have disc hemorrhages, especially repeatedly, are more likely to show progression in the course of time. That's just an example. And the factors that we uncovered were these. Racial heritage made a difference. And in particular, at the two extremes, Asians tend to progress slowly, whereas Caucasians more rapidly. Gender, females progress faster than males, especially if they had migraine. And thirdly, as we've already seen, disc hemorrhages increase the rate, especially if the hemorrhages were frequent. We found that all of these things we did not find affected the rate of progression at all. Now, many of these, the number of patients in the group was too small. And so they don't really count as showing that it did not affect it. But the ones with the asterisks, such as blood pressure, diabetes, family history of stroke, and so on, did show a relationship to how fast the field loss would occur. But most of the subgroups that we looked at simply had not enough subjects to make a conclusion. Risk factors for the prevalence help you clinically in knowing which patients to look to see whether they have normal tension glaucoma after you've already determined that they don't have a particularly bad intraocular pressure. Factors that affect progression help you decide the expected prognosis without treatment or with inadequate treatment, and so it affects how often you follow up the patient, and also affects the how aggressive your treatment is. With no other information, a new case of normal tension glaucoma has a 50% chance of being progressive in the course of 5 to 7 years. You could delay aggressive treatment just as you might for ocular hypertension, unless normal tension glaucoma damage is advanced, maybe already threatening fixation. You don't want to take a chance that there will be even a little bit of progression. You will also be aggressive in a case, for example, of a female with migraine and disc hemorrhages. That would certainly point to a higher risk, and a more aggressive treatment would be indicated. So clinically, the factors that affect progression are not the same as ones that affect the risk of having normal tension glaucoma in the first place. Understanding the traits that are linked to progression may guide your management, how aggressive it is. Moreover, understanding the traits that lead to progression, especially if it's fast, can also help identify pathogenic factors, so that you say, for instance, migraine or vascular dysregulation is something that will make for fast progress. It helps you understand, perhaps in detail, what the pathogenic factors are, that it's really something to do with vascular supply or with the regulation of blood flow or something like that. And it points the way to something that might be useful therapeutically. So it's good to keep in mind the things that we know about that and discover more about what affects the rate of progression. Here are the references to risk factors for progression. Oh, one more lesson. Lesson number 6. What is the benefit of lowering the intraocular pressure? Well, it turns out there's greater benefit if you're female, especially if you have migraine, greater benefit if there's a family history of glaucoma, and greater benefit if there's milder disease that's going to end up progressing faster. There is less benefit if you have disc hemorrhages at the baseline or along the way. There's less benefit if there's a family history of stroke, that is arterial occlusive disease, or if you have personal history, the patient himself has cardiovascular disease, heart attack, stroke, and so on. So we now have an analysis of 3 classes of traits. Traits that make a person more likely to have glaucoma in the first place, traits that affect the rate in which progression occurs, and traits that relate to how much benefit you get from lowering the intraocular pressure. We can also talk about what we might learn or suspect about the pathogenesis. Glaucoma with vascular occlusive disease, or more correctly, in patients with vascular occlusive disease or in their family, may behave differently from those that have vascular dysregulation, which used to be called vasospasm, and has Raynaud's phenomenon, migraines, and a number of different things that you need to learn about, but can't go over them right now. Intraocular pressure is more relevant with dysregulation and less relevant with arteriosclerosis, both for detecting the disease and for applying treatment. Here's a reference to this study. And to summarize everything that we've learned here, one is that a 30% lowering of pressure can be achieved with medications and laser alone in 30%. Secondly, that visual field criteria for progression are not very specific. Especially if you repeat the test, you're going to get some false positives. Thirdly, we've shown that in normal tension glaucoma, intraocular pressure is involved. That was what we set out to prove in undertaking this study in the first place, is whether intraocular pressure was involved in these cases. And we found that lowering intraocular pressure helps. The manner of lowering intraocular pressure matters in that surgery is more likely to cause either hypotony or cataracts or other complications. And so if medical treatment and laser will work, great. Normal tension glaucoma has a variable rate of progression, so you need to monitor carefully and determine whether this is a person with a rapid rate or a slow rate. There are traits that will represent underlying pathogenic factors that affect the natural course. Some of these traits are more affected by the level of intraocular pressure than others, and therefore have different degrees of pressure lowering that will benefit the patient. Some factors are genetic, some are gender related, and some are circulatory, either obstructive or vasospastic. Some of the pathophysiology might be affected by the level of intraocular pressure more than others, and that is the different cases will have different degree of benefit from lowering intraocular pressure. Noteworthy is that there are particularly 2 different kinds of vascular disease. One is microvascular disease, which is called these days vascular dysregulation. It used to be called vasospasm. It's represented by migraine, Raynaud's phenomenon, and various other signs that you can ask a patient about and recognize whether they have this tendency of microvascular disease or not. The other type, however, is obstructive arterial disease. They behave differently with regard to the intraocular pressure and have a different degree of favorable response to treatment by lowering intraocular pressure. One more lesson. There are indeed 2 populations of patients with glaucoma. Schulzer, the biostatistician in this study, and Drance, the co-principal investigator, had shown long before this study that there were two different populations with chronic open-angle glaucoma. And their course of disease, the severity of the disease, and response to treatment, and so on, all were different depending on whether they had obstructive arterial disease or vascular dysregulation, which fits very nicely with the findings of the normal tension glaucoma study. Well, I thank you for your attention.